All right, continuing our theme of neuro complications in the ICU, this is always such a helpful talk for me, and I think is a very changing field. So this morning we're welcoming Dr. David Greer from BU, who is a neurologist with a lot of expertise on this topic. Dr. Greer.
Great, thanks so much. I'll be talking to you about targeted temperature management and how to neuroprognosticate after cardiac arrest. Let me see if I can advance my slides. Uh, there we go. All right, so here are my disclosures. None of these are directly pertinent to today's talk, but these are them. All right, so we are going to talk first about targeted temperature management and go over some of the clinical trial data, and then who to do it in still nowadays and how to do it and troubleshooting around it because it is complicated and challenging. And then we'll spend a lot of time about neuroprognostication in a post-cardiac arrest patient who is not waking up. What tools can you use? What timing do you use them? What algorithms can you use? And what I call using your noggin and being patient, because often it's simply a matter of waiting in the appropriate patient for them to wake up. All right, but first let's talk about hypothermia. And targeted temperature management kind of goes across the spectrum, including normothermia. But hypothermia was really pardon the pun, a hot topic in the early 2000s. Sorry, I'm early with my dad jokes today. And why it worked was unclear, but it was thought to be a number of different things: to decrease the cerebral metabolic rate, cut down on cerebral edema and intracranial pressure, cut down on free radical reactions, inflammatory cascades, etc. So there was a lot of hand waving, but we were pretty excited about this. And I remember the first patient that we cooled when I was back at MGH years ago, when Taylor Thompson turned to me and said, "Hey, do you think we should cool this person?" And when Taylor Thompson said, "Should you do something?" He usually just said yes. And so we did. This was based on the new trials that had come out in the New England Journal. One is called HACA, hypothermia after cardiac arrest, which had 275 patients in it. And the other one was the smaller study, which had about 72 patients in it. But they showed that when you cool people, and the target was 32 to 34 degrees at that time, patients had a much more favorable outcome, going from 39% up to 55%, and death was reduced from 55% down to 41%. So this was really great. People were very excited about this. We didn't know exactly what temperature to cool to, but we were doing 32 to 34 for quite some time until this really great European group decided to say, well, might 36 be just as good as 33? So they did the original TTM, or targeted temperature management study, where they did just that. They randomized patients to 33 versus 36 degrees, and they had a very large sample size of over 900 patients, and they found 36 was just as good as 33 in terms of their time for death or their outcomes. If you looked at good outcomes, so here's the first two studies on top, the HACA study, which I mentioned, and then the Bernard study, which I didn't go into, and they showed that it was around 50% of patients would do well with targeted temperature management. And if you didn't get it, you had really poor outcomes, down to a quarter of the population did well with no cooling. In the TTM study, both populations did relatively well, about 50%. So that was kind of the mark to look for, regardless if it was 33 or 36. So it made me go back and look at the original temperature curves from the HACA trial, and were they actually keeping people normothermic in the non-cooling arm? And you can see that they weren't. That if you look at the error bars, a lot of the time these patients were actually going up into the 38 range, and they were certainly on average above 37. And so were these patients actually being compared to a standard of normothermia? I would argue no. So that kind of remained an open question, which I'm going to come back to in a minute. Most of the trials to that point had included mostly shockable rhythms, and we didn't know if non-shockable rhythms would have the same outcomes. Usually patients with non-shockable rhythms do worse, primarily because it's harder to resuscitate them, and they have longer downtimes, and they have more sinister causes. But I can tell you from a brain standpoint, the brain does not care what the rhythm is. If it's not getting blood flow and oxygen and glucose, it's going to do its thing. And so there's no reason why, if you have a relatively shorter arrest with a non-shockable rhythm, that the brain might do okay. So they randomized patients in the Hyperion trial to 33 versus 34 or 37 degrees for 24 hours. And the mortality was very high for everybody, no difference in mortality. But if you did survive, then you did better. You were about double the odds of getting to a cerebral performance category of 1 to 2 at 90 days. So again, maybe there was something neuroprotectant about that, and it didn't really affect survival, but it did potentially affect neurological outcome, which is what you want. But again, was the normothermia group normothermic? Look at the error bars on the normothermia group up top, which is the black dots, and you can see that a lot of them were frankly febrile, going even up to close to 39 degrees for a lot of the time, especially in the first 24 hours after the arrest. And so if fever is bad during that acute period, then you really got to keep them normothermic. All right. So if you thought that 33 versus 36 wasn't sexy, well, you're not going to like this at all. This is the TTM2 study where they did 33 versus 37. Whoa, that's exciting, keeping them normothermic. Well, it needed to be done. So this is a very well-designed trial of normothermia versus hypothermia to 33, and they had 1,900 patients. Remember, HACA trial was only 250 something. 1,900 patients in Europe and a few sites in the US, and they took cardiac and non-cardiac etiologies, and they took all rhythms except unwitnessed asystole. So they included a few things in here that we could slice and dice. They did a little bit better, but still not great at keeping people normothermic. And you might think, why is it so hard to keep people normothermic? Well, it's actually harder than you would think, because if you're trying to keep them at 37 degrees and they want to spike a temperature, they're going to get cold and start shivering pretty quickly for the other stuff that you're doing. So it's very challenging. And so I'm not sure that even this trial did such a good job of keeping people normothermic. It was probably the best of the ones I've shown you, but still not that great. There was no difference in any subgroup for the modified Rankin scale score. It didn't matter how you sliced and diced it, by age, by time to ROSC, or the initial rhythm. No, there was no benefit of 33 over 37. And you can just see this here on a Kaplan-Meier curve as well. What you did see was more arrhythmia with hemodynamic compromise in the hypothermia group. So you could cause more harm by doing this therapy. And I'll get into kind of like how you manage these patients to avoid that. But it's clearly a more dangerous therapy to take people to lower temperatures. So their conclusions, this is from the New England Journal, quote unquote, in patients with coma after out of hospital cardiac arrest, therapeutic hypothermia did not lead to a lower incidence of death by 6 months than targeted normothermia. All right. So where's the field going? Well, there is a trial, which I'll be honest, I don't love, which is called IceCap. And this was launched in 2016, and it's still going on. They aim to get 1,800 patients, and everybody is cooled at 33 degrees. There was no control group. There was no normothermia group. And they're looking at duration of cooling. So 12, 24, 48 hours, and they may look at 6 hours and 72 hours, including non-shockable rhythms. Again, no control group of normothermia. And again, they started enrolling in 2016. And I just looked yesterday that as of April 21st, which is a week ago, they have 1,135 patients. So why the NIH continues to fund this study with their very slow enrollment over almost 10 years now is beyond me. But the TTM investigators are still going at it, and why they decided to call TTM3 step care, I don't understand. But they're doing 3,500 patients, and they already have 1,500 patients. They're already blowing away the IceCap study. And you're going to love this, or maybe you won't. So they're doing avoidance of fever, so keeping people normothermic, or just letting them have a fever. Like, does fever protection even help these patients? Or is fever a natural thing that happens after cardiac arrest? I think that's pretty bold. The other thing I love about this study is that they're also doing sedation versus no sedation. I've never understood, as a neurologist, why we need to sedate a comatose post-cardiac arrest patient. If they want to wake up, why don't we let them wake up? Obviously, if you're having difficulty ventilating them, or if there are other reasons to keep them sedated, then fine. But if it's for the comfort of the tube, heck, we have people in the neuro ICU all the time that are chewing on their tubes that are doing pretty well and can cooperate with us. So if a post-cardiac arrest patient's waking up, just take the tube out. That'd be my suggestion for you, because they'll probably do okay in that setting. Not every patient, but consider it at least. All right. So what are the criticisms of the TTM studies? One of the big ones I hear from the ICECAP investigators was, well, they had way too much bystander CPR in the TTM studies. That's not realistic. And I think to myself, why don't we just do more education around bystander CPR in the US? If that's what made the population do better, that's where we should focus our energies, not necessarily by throwing more ice on the patient, but that's kind of where the field is going. All right. So you'd like to know who to cool and how long do you cool them for? So I personally recommend doing 37 degrees. You can do lower. There's no evidence that it really harms patients except for the arrhythmia issue that you have to keep in mind. If they come in lower than that, we usually keep their temperature at where they are at. If they arrest in the outdoors in the wintertime in a snowbank or something, then you keep them at that temperature, but at least 33 degrees. Some attendings will prefer 33 or 36. That's fine. Most people are doing fever prevention at 37 degrees for 24 to 48 hours. And that's what we're doing at our center. We do 37 for 48 hours. The cooling starts from the time that the clock starts from the time that you initiate the cooling, not the time they reach the target temperature. And we recommend a slow rewarming so that they don't vasodilate and get hypotensive, or vasodilate in their brain and get a high ICP. We use a cooling pad device to try to automate keeping the temperature where we need to have it. I already talked about shivering, but it is a problem, and it is not just a problem in terms of how to control it, but it's a problem in terms of what it does to the patient. It increases the oxygen consumption, the heat production, the metabolic rate, the work of breathing, myocardial consumption. These are all bad things. When you control the shivering, you can decrease the metabolic rate, decrease O2 consumption, and decrease CO2 production, but you need to adjust the ventilator to avoid hyperoxygenation and hypocarbia. So we tend to overventilate these patients. We put them on a lot of FiO2, and that's probably bad for their brains to have excess oxygen around because of free radical formation. And then we tend to overventilate from a hypercarbia standpoint as well. So they get hypocarbic and they vasoconstrict, and you don't want your blood vessels in your brain to vasoconstrict right after a cardiac arrest, because that's going to affect cerebral perfusion. So you want to aim for normoxia and normocarbia if you can. There are even studies that have looked at permissive hypercarbia in this setting. You get other effects with hypothermia, including intracellular shifts and renal tubular dysfunction that causes depletion of magnesium, potassium, and phosphate. Potassium goes into the cells when you cool them, and then it comes out of the cells when you rewarm them. And you guys fret about potassium even more than I do, and it's not great. So you have to treat whatever's going on at that time. Cardiovascular effects, the most common thing you see is bradycardia. You can get improved systolic function, but sometimes mild diastolic dysfunction. The blood pressure can go up because of vasoconstriction or go down because of cardiac dysfunction. If they have asymptomatic bradycardia, we usually tolerate it. But if they start becoming symptomatic and dropping their blood pressure, then we start to get more aggressive and treat it and try to get them back to normothermia if you can. Other cardiovascular effects include EKG changes, including prolonged PR intervals. You can do coronary reopening concomitantly with hypothermia. It does not cause increased arrhythmias. You can see Osborn waves, which I'll show you next. In general, other arrhythmias are less common unless they're severely hypothermic or they have significant electrolyte imbalances, or if their heart is really sick. So typically patients will get AFib first and then get VT or VF. Remember that the hypothermic myocardium is less responsive to antiarrhythmic drugs, and cardioversion is usually unsuccessful at lower temperatures, and it can convert AFib into VF. So you should avoid cardioversion if their temperature is less than 34 degrees. Here are Osborn waves, which are important, especially in a patient who's young and you don't know why they arrested. If they have Brugada syndrome, you're not going to be able to see that on this EKG because of the Osborn waves. You get coagulation, effects, but you can give thrombolytics safely with hypothermia. That has been studied. You get increased infection risk because of impaired granulocyte function. How do you know if somebody who's being treated with a temperature control device is developing a fever? Well, you look for the device to be working harder, and by working harder, it means the temperature on the device is going lower because either the patient's shivering or because they are trying to spike a fever. And it's very common and appropriate to check blood cultures and respiratory cultures as a surveillance. Drug clearance is affected by hypothermia, so enzyme-mediated P450 reactions are slowed by hypothermia, but the effect of drugs may be blunted as well. So use shorter-acting agents, boluses instead of maintenance doses, and keep in mind that longer half-life medications such as amiodarone are less effective because the amounts that are eliminated are low regardless. Other problems that you develop with hypothermia include impaired bowel function, delayed gastric emptying, mild elevations in amylase and LFTs, and hyperglycemia. I had a patient with really severe hyperglycemia, almost purely caused by the hypothermia. And once we rewarmed him, the hyperglycemia completely resolved. So I'm actually kind of glad that the field is moving away from hypothermia because this is a bear. There are a lot of things that need to be managed around this that are dangerous to the patient. And if it's really not that beneficial, which I think the Europeans have shown us nicely, then maybe normothermia is where it's at. Or maybe nothing is where it's at. And the step care study will tell us that. All right, I'm going to shift gears now and talk about neuroprognostication after cardiac arrest. So you have a patient who's not waking up after a cardiac arrest. What can you do to try to figure out how they're going to do? Are they going to wake up? And if they wake up, are they going to do well, or are they going to be mush? Sorry to use technical terms. Oh, and by the way, if they wake up right after cardiac arrest, how are they going to do? That's right. They're typically going to do pretty well. So this is really for patients who are not waking up after cardiac arrest. And you have the clinical exam, and I'm going to tell you, not just because I'm old school, but this is real. The clinical exam is still your best friend. And I'll tell you why. We'll talk about electrophysiology, which means SSEP and EEG. We'll talk about chemical biomarkers such as NSE, but there are newer drugs as well, not drugs, newer biomarkers as well. And we'll talk about neuroimaging, including CAT scan and MRI, and when you get them. If you cooled the patient, keep in mind that hypothermia is going to mess up your neuroprognostication. You have delayed recovery, which is more common. You have cold neurons that are dysfunctional, but they're not dead. And medications that you gave when they were hypothermic will linger for longer. So you have to take all those things into account. So your electrophysiology and your neuroimaging may show delayed or attenuated changes also. So that throws a little bit of a wrench into everything. The first practice parameter from the American Academy of Neurology came out in 2006. It's amazing that almost 20 years later, we don't have a second practice parameter, and that needs to be corrected. But I will tell you from their guidelines at that time, which are still in effect, they said the prognosis is invariably poor in comatose patients post-arrest with absent pupillary or corneal reflexes or absent or extensor motor responses 3 days after cardiac arrest. So first of all, wait 3 days, period. If there's confounding, wait longer. If they got cooled, wait longer. I will tell you that extensor or no motor response is no longer valid. That you can have patients who have a poor motor response who can still make a good recovery. The pupils and the corneals, if absent, are still something you can hang your hat on, but not the motor exam. All right, and how do you test pupils and corneals? So first of all, we have automated pupillometers, which are great. But if you can see me on the screen right now, I have the original pupillometer, which is a handheld magnifying glass with a LED light. So I get the pupil in focus and I'm shining the light and I'm looking very meticulously for any pupillary reaction. A pupillometer can be extremely helpful. I have no stock in the company or anything like that. But this is a matter of life and death. You really need to see if there's any reaction or not. And that's, again, 3 days post-cardiac arrest. All right, how about a corneal reflex? So who here, show of hands, don't worry, I can't see your hands. Who here uses a saline squirt to check for a corneal reflex? So I do, because if they blink to a saline squirt, you're done. You know that they have a corneal. But if they don't blink to that, then I will take out of my pocket. I'm like a magician. I carry all these things in my pocket. So I've got Q-tips in my pocket, and I'm going to touch the eye and actually press on the eye, and I want to see it move. And where you touch on the eye is really important. So here's a heat map from a survey that we did of over 900 intensivists and neurologists to say, where do you touch on the eye? And you can see that people were really pretty far lateral. Some people miss the eye entirely, which is just sad. But the farther you get away from the iris, the less sensitive the eye is out here. So you want to touch right at the border of the iris, and you want to press lightly to make sure you can see a reaction. So first of all, I'm going to show you some examples. These are all with permission of the families. This is my handheld magnifying glass. You can see this patient has ocular dipping, and his pupils are reactive. And here's a pupilometer, which is very easy to use. I'll turn off the sound. You just point and shoot. You just get it lined up, and you get the pupil in the center, or even close to the center is okay. It does not like it when it doesn't see a reaction, so it always checks a second time. Boom, right there. So I always miss the timing. But the pupilometers are always going to double check, which is a nice feature. All right, testing the corneal reflex. I'm going to show you this as well. This looks a little gross, but you're not going to puncture the eye or injure it. I'm going to take the Q-tip and touch right adjacent to the iris and press. Now I know that patient has no corneal reflex. So that's a definitive test. Why am I so meticulous about this? Is it really a matter of life and death? Yes, it is. Like if they have a corneal versus no, you want to be really accurate about that because that's going to be one of your most definitive things. So pupils and corneals, if either one is absent bilaterally, at least 3 days post cardiac arrest, nearly 100% specific that they're going to have a poor outcome. If they're present, it doesn't mean they're going to do well. They might not. But if they're absent, you can hang your hat on it. All right, how about SSEPs? Not everybody knows about this electrical test, but it is so old. It's from like the 1940s or 50s, and it's really simple. You just stimulate at typically the median nerve, and you're following that impulse all the way up through the brachial plexus, through the spinal cord, through the brainstem, to the contralateral somatosensory cortex. And what you're looking for at the very top there is called the N20 potential. N20 is also called the cortical potentials. That's basically saying that you sent an impulse from a sensory nerve all the way up and it reached the cortex. So if it gets all the way up to the thalamus, but then doesn't get to the cortex, don't have to be a neurologist to know that's bad because that means your electrical pathways are not intact. So again, we're looking for that thalamocortical N20 response. Very helpful if the patient has an unreliable exam, if they're paralyzed or sedated. Maybe inaccurate if they've got focal structural lesions, such as a prior stroke or a subdural or something like that. Or if they're hypothermic and can be misleading if performed too early. So here's a single patient who was studied serially, and you can see at 4 hours, they had very poor waveforms, really anything past the neck. And so you could think, well, that's just really bad. But they studied this patient serially, and they saw that actually all their waveforms recovered, and the patient themselves recovered. So we wait at least 48 hours post arrest, or if they got cooled, at least 48 hours post complete rewarming. Now, the data for this is based on what's called the PROPAC study, which was a Dutch ICU study where they found in over 400 patients that if you had absent bilateral N20s, you had a very low false positive rate for predicting poor outcome. Again, it's good at predicting poor outcome, not great at predicting good outcome. My only caveat about this relatively well done study is that they had a lot of early withdrawal of care. They had almost a quarter of patients who had withdrawal of care at 24 hours post arrest. That's way too early. I almost never withdraw life-sustaining therapy before 3 days unless they're clearly brain dead or dying for other reasons. So I always have to worry about the self-fulfilling prophecy bias in that study. So the AAN says you can trust the absence of cortical SSCPs within 1 to 3 days. I would actually say at least 2 days. And then ESICM, which is the European Society of Intensive Care Medicine, said bilaterally absent SSCPs at least 24 hours without therapeutic hypothermia. But wait, if they did get cooled, because we reported a case, and then my friend Christoph Leithner reported a case also of patients who were hypothermic who initially had absent N20s on their SSEPs who then recovered, and not just recovered, but regained cognitive function as well. So great test. I use it, but you got to wait. Helpful in predicting poor outcome. Maybe the amplitude of a present N20 may help to predict good outcome. We don't know yet. It's least susceptible to medication or metabolic effects, which is great. Timing of the study, I've already hammered home, is crucial. Wait at least 48 hours and longer if they got cooled, because you can get false positives in a setting of hypothermia. All right, EEG, not SSEP. EEG, so keep in mind your EEG can look like crap early on, and then it can slowly evolve and get better. So don't read too much into your first EEG. Here's an example of that. At 3 hours, this kind of looks like a burst suppression here. You have burst and then suppressed and then another burst here. Same patient at 7 hours. Hey, that's looking a little bit more organized. 17 hours. Whoa, that looks like it's got good rhythms. 33 hours, that looks normal. And you may be a cardiologist and saying that looks like VFib. Well, when we see VFib on an EEG, we like that. We don't like what VTAC looks like on an EEG, but VFib is perfect on an EEG because that means normal alpha rhythm. So that's really good. All right, let's say a patient has myoclonic status epilepticus. I don't know if you can see me on the screen, but you've probably seen myoclonus at the bedside. It looks like this. Very violent shaking, eyes blinking, face, eyes wide open sometimes. It looks really bad, right? And that's always got a poor prognosis, right? Well, maybe not. So historically, they said, yeah, if you got myoclonic status, these patients typically do really badly. These are some of the giants in the field: Harlan Krumholtz, Brian Young, Elko Vadix. They all said myoclonic status is really bad. Except for these case reports. Well, they had 1995, a lady who they were saying their goodbyes to. They withdrew respiratory support because of her myoclonic status. And wouldn't you know, she not only survived, but got normal cognitive function. Oopsie. 1993, 1998, 3 patients with myoclonic status all had good recovery. So when these reports came out, we started thinking, why do patients with myoclonic status do so poorly? And anybody that's got kids knows this character discussed from the movie Inside Out. Again, I have no stock in that movie either, unfortunately. But it's really hard to look at somebody who has myoclonic status and they're jerking around in the bed. So what do? You call neurology and we start giving them baclofen and Depakote and Keppra and all this stuff which affects their mental status so they don't wake up. So we need to stop piling the junk on. Usually the myoclonus goes away after a few days, and always get an EEG when you see myoclonus because you can't tell based on what it looks like phenotypically if they're seizing or not. So Jonathan Elmer and Cliff Calloway and their group down at UPMC, where they're doing amazing work in post-cardiac arrest, they looked at 2 different patterns that you can see in myoclonic status. One of them has a much better prognosis than the other. And so if you have a continuous background, that's the thing to keep in mind. A continuous background, that's much better than a non-continuous background. All right, let's say you hook them up and they're an electrographic status epilepticus. Well, that's got to be bad, right? Well, you can't trust me when I say that anymore, right? So I see seizures. I'm like, woohoo, I know how to treat that. I'm a neurologist. I got drugs for seizures, even status epilepticus. So I treat them aggressively. And there are reports of others who've done this, who've gotten patients to have actually reasonable outcomes. So the only rhythm that I really worry about in post-cardiac arrest is what I call low and slow, when it's just really not generating a lot of electricity. That's a burnt out brain. If I see electrical activity, that's better than not. How about reactivity? You may have heard of reactivity on EEG. So you can see there's a little black box way at the top up here. So this EEG is just chugging along, and then somebody claps or yells or pinches the patient, and the EEG changes. It actually got a little flatter here. That's fine. It just shows that you got a message into the brain, and the brain reacted somehow, at least based on the brain waves. So reactivity is better than not. All right, so the guidelines are pretty worthless around this. The AAN says burst suppression, generalized epileptiform discharge, insufficient prognostic accuracy. ESICM was pretty bold. They said poor outcome very likely, with unreactive burst suppression or status epilepticus. I just frankly disagree with that. I don't think that that's accurate, and there are probably patients that we can save. So I love EEG post-cardiac arrest. I use it early and often. I'll use it continuously, typically. If they show seizures or an active EEG, I'll often treat that aggressively. If it shows status, I'll treat that aggressively also. So look at this as one of your best friends to look inside the brain and understand dynamically what's going on electrically at least. All right, biomarkers. So the one that we use most often is called NSE, or neuron-specific enolase, and it's a little bit of a misnomer. It is not specific to neurons. You also have NSE in red blood cells and platelets, as well as some neuroendocrine tumors and pancreatic cancers. But the red blood cells and platelets are important because often your cardiac arrest patients are hemolyzing and spilling NSE into their bloodstream that's not coming from the brain. So I always check NSE serially, and I'm looking for the level to go up as the patient is getting less sick. If the level is going up, that's probably reflective of it spilling from the brain and not from your red blood cells and platelets. The initial studies gave us this cutoff of NSE of 33. That is way too low. There are patients who have good outcomes that have had much higher NSEs than that, so that's very dated. ICM doesn't know what to say in terms of what a cutoff level should be. So amazingly, they said poor outcome very likely with, quote, high NSE levels, but they didn't define what high was. So I think that's the ultimate in hedging, but I understand why they did it. There are other biomarkers that are being studied. And I would say what makes an optimal biomarker? You want it to be both sensitive and specific for the organ that you're trying to measure. And so maybe even doing lumbar punctures on these patients might be the future in patients who aren't at risk to herniate, because that would be a safe haven where you could look just at the CSF, assuming that it's not a bloody tap. But I'm going to put the plug in your ear for a couple of newer biomarkers. So first, tau. You may have heard of tau in Alzheimer's disease. We also can look at tau in post-cardiac arrest to see if it's spilling into the bloodstream. And this performs significantly better than NSE, at least from the TTM study. And then from the coma care study, they looked at something called NFL, or neurofilament light chain. I think this is going to be the real marker that we should be using moving forward. This appears to have very good sensitivity and specificity for the brain and for brain injury in particular. So not commercially widely available right now, but we're working on it. So take-home lessons, I would say biomarkers are useful in predicting poor outcome, and low levels may be predictive of good outcome. As opposed to some of our other markers, this is one that may help to predict a good outcome if they have low levels of these biomarkers. I never rely on any single value. I always follow a trend. There are a lot of false positives that can occur. Laboratory delays are real, and so a lot of caveats to this. All right, and then neuroimaging. There's CAT scan and MRI. We don't use PET that much. Hypothermia can delay the changes that you'll see. We did a large study using CT, which I still find very valuable. And then we did a somewhat smaller study, but 80 patients with MRI post-cardiac arrest. And so these are very useful adjuncts as well. And I would say use them, but time them well. If you get a CAT scan on admission, that may not show you very much, and that's fine. That CAT scan on admission is really to rule out a hemorrhage as the cause of their arrest. So I get another CAT scan on day 2 or 3 post-arrest. If that's still not showing me very much, then I'm going to get an MRI after that to see, because it's much more sensitive. But a nurse will tell you they'd much rather go for a CT than an MRI. It's a much safer environment for the patient. So I'm usually looking to hopefully stop after getting a CT and not going to the fancier test. Oh, speaking of fancier tests, here's the fusion tensor imaging, which is really cool. This is a way of looking at the integrity of the white matter tracts, and you don't have to be a neurologist to know that you got less spaghetti on the right side in a patient with poor outcome. That's just simply because the white matter tracts were dying off on the patient on the right. The patient on the left had much more integrity with the white matter. So these are some of the cooler things that we're doing. All right. So ESICM, or the European Resuscitation Council, has had a couple of really good guidelines that came out, 2013 and 2021. I like the 2013 one better, and I'm not sure what they did in between. but I'll tell you why I like it. So first of all, they say exclude confounders, rewarn the patient. You can see up here, they're not doing any prognostication for the first 2 days. Nothing, nada, zippo. Then they use the motor exam as a screening tool. If you got a motor of 1 or 2, all right, that may be a patient that's going for a poor outcome, but they're not using it as a deciding tool. They have pupils and corneals and SSEPs as their most definitive start up front with that. And I pretty much agree with that, that you could make a decision based on that at around day 3 if there's no confounding. But I love this. They say, wait, if it's not that, then wait a little longer. Oh, what a novel concept. We're going to wait a little bit and see how the patient does. Great. And then they say 2 or more of the following. So status myoclonus, I don't agree with that. High NSE levels, what's high? Unreactive burst suppression or status epilepticus, I don't agree with that. And then they say diffuse anoxic injury. What does that mean? Is that a little bit of patchy anoxic injury here? Is it fluoride changes? They don't define it. But then they win me back and they say indeterminate outcome. And I love this. They say multimodal neuroprognostication whenever possible. And then inconceivably, if you've seen Princess Bride, you remember that line. Why did they actually do this? They lumped everything together. They said any 2 of these 6 things were equal, and that's just completely not true. So please don't use the more modern 2021 ESICM guidelines. I do like that they said this. So targeting a higher MAP, trying to decrease lactate, those are both really good things. Targeting a normal oxic state and targeting normocapnia, as we talked about earlier, is super important in these patients. Can't we study this better? And I will tell you, yes, the most important thing is doing standardized testing at standardized time points, using all the tools in our tool chest, and perhaps letting the right patients live for longer to see if they're going to make a recovery. So we are doing a R01 funded study right now, a cooperative study between 5 US centers and 5 centers outside the US, 4 in Brazil and 1 in northern Italy. Why those places? Well, those are places where they don't withdraw life-sustaining therapy prematurely. How early do we typically pull the plug in the US? On average, day 2 to 6 post-arrest. Before day 3, I almost never know how the patient's going to do. So that's a little scary, right? How many patients have we withdrawn life-sustaining therapy on who might have gone on to recover? In Brazil and northern Italy, the average day of withdrawal life-sustaining therapy is 22 days post-cardiac arrest. So in theory, if you match a patient in Brazil with a patient in the US, and they have very similar characteristics, very similar exams on day 3, we got full of ourselves in the US and we decided to say poor prognosis and the patient died. This patient was discharged home. They were ambulatory by the time that they were discharged, and at 82 years old, they were still ambulatory and living at home at a half a year. So you never know until you wait. So that's why we're doing that study. And then we just finished this study and we'll be hopefully publishing the results this year. It's called the MOCA study. And don't you love this little brain on the latte up here? Very nerdy. That's how neurologists roll. This is a neat study where we did functional MRI and functional EEG. So they're in the scanner and we play music or ask them to imagine they're walking through their house or playing tennis. And the blood oxygen level will go up to more metabolically active tissue. So the patient might look totally comatose, but their brain lights up. So I like to call this, wait for it, the lights are off, but someone is home study. I know it's nerdy, but it's so exciting. Like maybe if you see this, it's a better prognostic sign than if not. So we'll let you know later this year. So I know I only have a couple of minutes left. This is what you've been waiting for. This is what you should do, a combined approach. Use your exam. And no, I don't know what they're doing to this poor patient. It looks like a prefrontal thump. We don't hit people in the head to wake them up. We hit them in other places. Use your CAT scans, use your SSCPs, your EEG, your NSE, throw it all together into what I call the prognostic soup. Here's the timing, your pupils and corneals at 72 hours post-arrest and rewarming. If they are absent and there's no confounding, then that patient's going to do poorly. That's the one thing you can really hang your hat on. EEG, do it daily, continuously if possible. If you see seizures, treat them, check for reactivity. The only thing I really don't like as a malignant pattern is low and slow, low amplitude, slow waves. CPs not earlier than 48 hours post-arrest. If they have bilaterally absent cortical potentials, that's bad. NSE, I trended over 3 to 5 days. It may take forever to come back, but that may help you if you're waiting on a patient that you're just really unsure about. CT on admission to rule out a bleed. CT for prognosis on day 2 to 3. And then if that doesn't tell you enough, then an MRI around day 3 to 5. And that's going to be the sweet spot to show you your diffusion weighted changes. All right, in conclusion, temperature regulation is important for now, at least keeping people normothermic. And then step care will tell us whether we need to do anything with temperature. Neuroprognostication is a moving target. All studies to date have significant biases, primarily withdrawal of life-sustaining therapy. Any and all tests should be viewed within the clinical context to make sure that there's no confounding. And if somebody is 96 years old with metastatic cancer, throw that into your prognostication also. I look at it only from the brain, but you should be looking at it holistically. Hypothermia will impact neuroprognostication, and when in doubt, give more time. So that's my last slide. 8 seconds left. Angela, I must have nailed it this time, huh?